Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we will be talking about peripheral neuropathy, and as I've been stressing before, are we talking only about the important concepts of peripheral neuropathy? But what is peripheral nervous system and peripheral neuropathy? Peripheral nervous system is the nervous system where the structures lie outside the pile matter of the brain and the spinal cord. So peripheral nervous system are the structures which lie outside the pile membranes of the brain and spinal cord, except first nerve and second nerve, because they are extensions of the brain. So peripheral nervous system, neuropathy, pathy means there is some disorder or some problem with the system. So we are going to talk about now peripheral neuropathy, diseases of the peripheral nerve. But before I talk the approach to peripheral neuropathy, which is very fascinating based on a 7-question approach, let me touch upon the basics and symptoms of peripheral nervous system so as to understand these 7 questions by which we can approach peripheral neuropathy patients confidently. So what are the symptoms and basics? First is the motor. We'll be talking about the motor, sensory, then the deformity and the tropic changes, autonomic nervous system and fasciculations. When I talk about motor, we need to talk about weakness. Here there is one important concept: axonal neuropathy and demyelinative neuropathy. Axonal neuropathy is a length dependent neuropathy. Axonal neuropathy is a length dependent neuropathy, and therefore the distal parts only get affected first, the feet and the hands, and then they start ascending, because the nutrition has to take a long time, it has to travel a long course to reach the distal parts, and therefore in peripheral neuropathy the first things to get affected are the distal parts. So if it is sensory, call it as a glove and stocking type of sensory loss. So weakness, if it's an axonal type of neuropathy, it's a length dependent neuropathy and the feet and the hands get affected first. But if it is a demyelinative neuropathy, because of its focal, multifocal nature, proximal parts also get affected early. Proximal parts may get affected early or equal to distal parts, and even the cranial nerves get affected, like the acquired demyelinating neuropathy where the 7th nerve gets affected in Guillain-Barré syndrome. So axonal neuropathy is a length dependent neuropathy. The weakness are seen in distal parts, the hands and feet, whereas the demyelinated neuropathy is a length independent neuropathy, multifocal. So proximal and distal get affected equally, and the cranial nerves also can get affected. Second thing, when we talk about the atrophy, again atrophy is well seen in axonal neuropathies. In demyelinating neuropathy, atrophy is not that much seen. Because of absence of denervation, atrophy is not that much seen in demyelinating neuropathy. So if you see atrophy, it is an axonal type. And another important point regarding the motor system involved in peripheral neuropathy are tendon reflexes. The tendon reflexes, they are lost in large fibers. Example, vitamin B12 deficiency. But they are preserved in small fibers. Why deep tendon reflexes are lost in large fibers? Because if you take the deep tendon reflex, the afferent, the sensory part is basically large fibers, and therefore generally only in large fiber neuropathies, example vitamin B12, the deep tendon reflexes are affected, and in small fiber neuropathy they are not affected. Right. This is about motor system. Now let's talk about the basics of sensory. In sensory, you need to understand an important concept: small fibers and large fibers. Small fiber neuropathy and large fiber neuropathy. Small fibers, they carry pain and temperature sensations. So if small fibers get affected, there is a pain and temperature lost. Large fibers carry position and vibration sense, proprioception. So if large fibers get affected, position and vibration sense are affected. Then in a sensory neuropathy, there could be paresthesias, pain, and dysesthesias. Paresthesias are the spontaneous occurrence of pain. Dysesthesias are abnormal sensations which are perceived as pain, and then we can have pain. So paresthesias, usually they'll be having spontaneous pain and pinprick like sensations. Dysesthesia, any abnormal sensations are perceived as pain, and then we can have pain also. Then another important point in sensory neuropathy is that they can have ataxia. The sensory ataxia because of the root involvement, posterior root involvement. Example in Guillain-Barré syndrome, the Miller-Fisher variant, where the roots get involved and therefore they can have ataxia, or the large fibers can get affected, the proprioception, and then they can have ataxia. So ataxia can be because of the posterior roots or because of proprioception, and the Miller-Fisher variant of the Guillain-Barré syndrome also there will be ataxia. Right. Next we'll talk about the deformity and trophic changes. The deformities are usually seen in chronic neuropathies or hereditary neuropathies, where the skeletal system, especially the foot, is involved nearly in 30% and the spine is involved in nearly 20%. So in chronic neuropathies or hereditary neuropathies, there is involvement of foot and the spine. Why is foot involved? Why is there a high arched foot in a long-standing neuropathy like hereditary neuropathy? There is a disproportionate weakness of the pretibial muscles, and therefore there is plantar flexion. There is weakness, disproportionate weakness of the intrinsic muscles of the foot. Therefore there is a high arched foot. So therefore when you see a high arched foot or pes cavus, it indicates a long-standing neuropathy like hereditary neuropathy. Not only foot, they can have even the kyphoscoliosis or the spinal abnormality. Why do they have kyphoscoliosis? Kyphoscoliosis is again because of the unequal weakness of the paravertebral muscles. Because of the unequal weakness of the paravertebral muscles, they can have kyphoscoliosis. So if we see kyphoscoliosis or pes cavus, it indicates a long-standing neuropathy, a very chronic neuropathy like hereditary neuropathy. Then they can have trophic changes. Trophic changes basically because of loss of C fibers, where the autonomic nervous system is involved, the pain is involved, and therefore they have painful repeated injuries, infection causing trophic changes. Example, syringomyelia. Right. Now we have seen motor, sensory, deformity and trophic changes. Next we will see the autonomic. Autonomic nervous system also can get exclusively involved. The basic two important points one has to look for in autonomic involvement is anhidrosis, loss of sweating, and orthostatic hypotension. Physically you can check the variation of the heart rate to respiration, postural changes, etc. So we have to look for the autonomic involvement also. Then we look for fasciculations, cramps and spasms. They are thought to be due to haptic transmission or Canon's law of denervation supersensitivity, or because of the neuronal sprouting seen in denervation. So these are all the symptoms which we have to analyze when we start approaching a patient with peripheral neuropathy. Now, having understood the basics and the pathophysiology of the symptomatology in peripheral neuropathy, now let's see how we approach a person with peripheral neuropathy. One of the excellent articles about the approach of peripheral neuropathy is about the 7-question approach. The 7 key question approach to peripheral neuropathy. If we understand these 7 key questions, approaching a patient of peripheral neuropathy becomes very, very easy. In fact, it is exciting, really, we can feel really happy, euphoric to approach a person with peripheral neuropathy based on these 7-question approach. The best approach to patient with peripheral neuropathy is this 7-question approach. What are these 7-question approach and what are these 7 questions? First, we need to find out what systems are involved. Suppose a person comes with peripheral neuropathy, always ask these 7 questions. The first question is, what structures are involved? Whether it is motor, like porphyria, or sensory, or autonomic, or mixed, like diabetes mellitus, where it affects all the systems. First is the structures involved, whether it is motor, sensory, or autonomic. The second question is, what is the distribution of the weakness? As I told earlier, if it is axonal, it is a length dependent neuropathy. So the distal parts get affected, the foot and the hand. Sensory also, the foot and hand are lost, so you have a glove and type of sensory loss if it is axonal. If it is demyelinative, proximal and distal are equally affected along with the cranial nerves. Then we have to find out what parts are affected. If it is focal, it could be carpal tunnel syndrome. If it is asymmetrical, it could be mononeuritis multiplex. If it is symmetrical, it could be diabetes mellitus. So we should know what is the distribution of the weakness, whether it is purely distal like an axonal neuropathy, or distal and proximal equal with cranial nerves like demyelinating neuropathy, or focal like carpal tunnel syndrome, or asymmetrical like multineuritis multiplex, mononeuritis multiplex, or if it is symmetrical like diabetes mellitus. Right. Now, what is the nature of sensory involvement? We have to find out what is the nature of sensory involvement. Whether small fibers are involved or large fibers are involved. Small fibers, as I said, pain and temperature are involved. The classic example is diabetes. Large fibers, proprioception, position, joint, vibration sense involved. The classic example is vitamin B12. Next week we have to see whether, along with the peripheral neuropathy, whether there is any upper motor neuron involvement, corticospinal tract involvement. There are many examples. One classic example is vitamin B12, where it affects even the corticospinal tract. So peripheral neuropathy with corticospinal tract, if it is there, there are few conditions. One of it is vitamin B12. The next question we should ask is the temporal evolution, whether it is acute, less than 4 weeks like GBS, or 4 to 8 weeks subacute, or more than 8 weeks chronic, or whether it is relapsing in type like porphyria, CIDP. Fine. The next question we should ask is that whether there is any hereditary component, whether it is a long-standing present since childhood or not. If it is there a hereditary component, there should be we should talk about two important points. One, we should always see whether these skeletal abnormalities are there. As I said earlier, hereditary neuropathies, generally the foot and the spine are affected. Foot, there is high arch foot because disproportionate weakness of pretibial muscles and intrinsic muscles of the foot. There is high arch foot. Because of unequal weakness of paravertebral muscles, there is kyphoscoliosis. Then, another important point, I'll talk during electrophysiology, but here I would like to just touch upon. In hereditary neuropathies, if we do nerve conduction studies, the conduction velocity will be uniformly decreased throughout the body. I repeat, there is a uniform decrease in conduction velocity throughout the body. Why? Because in hereditary neuropathy, all nerves are equally involved, and therefore the conduction velocity is decreased throughout the body equally and uniformly if it's a demyelinating neuropathy. Then we should always ask about associated features. For example, patient may be having diabetes mellitus, which gives rise to diabetic neuropathy, or patient may be having diarrhea. You would have had history of diarrhea infections, especially Campylobacter jejuni, which would have given rise to Guillain-Barré syndrome, or he might have undergone gastric surgery, and because of that there could be a vitamin B12 malabsorption, or it could be medications and toxins like vitamin B6 deficiency, or person may be taking too much of alcohol, which gives rise to vitamin B1 deficiency, thiamine deficiency, or any dentures and the creams containing zinc, which decreases copper. So you should always ask history of associated conditions like diabetes, infections, surgery, toxins, alcohol, and any dental cream appliances. So these are the fundamental 7 questions one has to ask when they are trying to approach a person suffering from peripheral neuropathy. The structures involved, the distribution of the weakness, the nature of sensory involvement, whether the upper motor neuron is involved, what is the temporal evolution, and is there any hereditary component, and other associated conditions. Fine. Now, having understood the symptomatology and the approach, let's discuss the electrophysiology. Electrophysiology basically consists of 2 components. One is the nerve conduction studies, second thing is the EMG. Nerve conduction studies and EMG. Now, neuropathy, as I said in the early part of my lecture, basically we have axonal type and demyelinative type. Axonal is the center part, the demyelinating is the part covering the axon. So when there is an axonal neuropathy, when you do nerve conduction studies, the amplitude is decreased, but the conduction velocity is normal. So axonal neuropathy, when you do nerve conduction studies, the amplitude is decreased. And when we do EMG, EMG is putting a needle into the muscle. So when you do EMG, put a needle into the muscle, we see fibrillations. The fibrillations is because of Cannon's law of denervative supersensitivity. So we see fibrillations on EMG, and in nerve conduction studies amplitudes are decreased. If this is the kind of report which we are going to get, it is axonal type of neuropathy. Now let's see what happens in demyelinating neuropathy, the nerve conduction studies. But before I start off the nerve conduction studies about demyelinating neuropathy, I need to talk about saltatory conduction. What is saltatory conduction? When the nerves are well myelinated, an impulse jumps from one node of Ranvier to the other node of Ranvier, and therefore myelinated nerves will have a very good conduction velocity, a very fast conduction velocity, and therefore when the myelination, the covering gets affected, the conduction velocity gets decreased. So in demyelination, the conduction gets decreased and all the fibers will have a differential kind of conduction velocity, and therefore they do not get uniformly decreased. There will be temporal dispersion. So decrease in conduction velocity and temporal dispersion is characteristic of demyelinating neuropathy. So if we take the demyelinating neuropathies, when we do the nerve conduction studies, the conduction velocity is decreased. As I said before, the conduction velocities, if it is uniformly decreased throughout the body, all four limbs, it is a hereditary type of neuropathy because all are equally affected. Suppose if it is an acquired type of demyelinative like neuropathy like Guillain-Barré syndrome, they are not uniformly affected, they are non-uniformly affected. So there may be a conduction velocity better, and in some limbs if you do it may be lesser. So a non-uniform decrease in conduction velocity is seen in acquired neuropathies like Guillain-Barré syndrome. And I said because the conduction velocity is slowed down, the distal latencies are prolonged and there will be temporal dispersion. And again there will be late potentials also, F wave and H wave. The F wave is because of the retrograde and anterograde traveling through the motor nerves coming through the roots, that's why F waves gets prolonged in Guillain-Barré syndrome. H wave is because of the sensory and then coming back by motor. So the late potentials are seen in the demyelinated neuropathy. There will be prolonged distal latencies, the conduction velocity is decreased and there will be temporal dispersion. And if you do EMG, the fibrillations are not there. If fibrillations are there on EMG, it's an axonal type of neuropathy, but in demyelinated neuropathy, the fibrillations are not there. And one more important point I need to talk about radiculopathy is that in radiculopathy there may be sensory loss, but if we do sensory nerve conduction studies, it will be normal. Very fascinating. In radiculopathies, there could be sensory loss, but if we do sensory nerve conduction studies, it is normal because as long as the dorsal root ganglia is intact, the sensory nerve conduction studies are normal. So in radiculopathy, the lesion is proximal to the dorsal root ganglion, indirectly indicating that the dorsal root ganglion is intact, and therefore the sensory nerve conduction studies are normal. So sensory nerve conduction studies are normal, but there is sensory loss, always think of radiculopathy, right? Now, having understood the basics, approach, electrophysiology, now let's talk about the treatment. What is the first line treatment for peripheral neuropathy? Tricyclic antidepressants, amitriptyline, gabapentin and pregabalin. So first line treatment is amitriptyline, gabapentin and pregabalin. The second line treatment is carbamazepine, phenytoin, tramadol. So the second line treatment is carbamazepine, phenytoin, tramadol. The third line treatment is mexiletine, and the fourth line treatment is capsaicin cream. So these are the various lines of treatment of peripheral neuropathy. First line tricyclic antidepressants, gabapentin, pregabalin. Second line is carbamazepine, phenytoin, tramadol. Third line is mexiletine. Fourth line is the capsaicin cream. Right. Now, having covered the overview, having given the overview of peripheral neuropathy, what are the important points one need to understand? One, as a person comes with peripheral neuropathy, we should know whether the motor or sensory or an autonomic nervous system is involved. And sensory, if it's there are two types: large fibers, small fibers. Small fibers carry pain and temperature. Large fibers proprioception, position and joint sense. And if you think it's a case of hereditary neuropathy, you should always check out on the foot and skeletal deformities because they usually get affected in a long-standing neuropathy. And if you do electrophysiology, if it is axonal type, amplitude will get decreased. If it is demyelinative type, the conduction velocity will get decreased. If it is a non-uniform decrease in conduction velocity, is an acquired type of neuropathy like Guillain-Barré syndrome. If it is a uniform slowing, it is a hereditary type of neuropathy. And of course, in demyelinating neuropathies like Guillain-Barré syndrome, you find late potentials. And if sensory nerve conduction studies is normal despite sensory loss, the lesion is proximal to the dorsal root ganglia, that is radiculopathy. So I've discussed so many causes, but what are the important causes of peripheral neuropathy? You can remember it by rule of 3. If 1/3 of the causes of neuropathy is because of diabetes, so diabetes is the most common cause of neuropathy. So any person comes with neuropathy, the first thing you have to suspect is diabetes. So 1/3 of the causes of neuropathy is diabetes. Another 1/3 of cause of neuropathy are other causes like hypothyroidism, nutritional, metabolic. And 1/3 of the causes of neuropathy we do not know despite extensive evaluation, idiopathic. So rule of 3, 1/3 of neuropathy is because of diabetes, 1/3 is because of other causes, and 1/3 we do not know, it is idiopathic. I really enjoyed giving this lecture, and I hope you have also enjoyed listening to my lecture. If you have liked the lecture, please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts. Bye.